All right, everybody, is your eye expert Dr. K, and I wanted to show you this case. This patient is not well positioned. It's due to a neck problem. See how I make this incision here? You're going to watch. I want to show you this. It comes in at an angle. It's not really perpendicular to the limbus. So already we're starting off with not the best side port incision. It's because my positioning isn't good, because the patient has some kind of neck issues. Can't really even get the cannula all the way in as we would like, but we can get a good viscoelastic fill. Now we'll make our mark on our cornea and we'll make our main incision. Now watch this main incision. You'll see that's too far posterior, and it does get some of the limbal vessels, which is good, but also gets the conj. So what can you expect? You can expect some conj ballooning there from fluid egress that gets under the conj. So we'll have to look out for that later in the video. All right, now we're going to start our capsulorhexis. Watch how I make my capsulorhexis. As we get to this portion here, we're doing a little bits at a time, just gradually pulling slowly, slowly, slowly. The reason is that one, my positioning isn't good, and two, I don't want the rhexis to go out, so I don't make these huge kind of maneuvers, just small maneuvers at a time, especially in an area where it's hard to visualize over the cortex. So just little maneuvers when your positioning isn't good and when its visualization is difficult. Now we will do our hydrodissection, hydrodelineation. Didn't get a good hydrodissection wave that first time around. Why? Because I stuck it right where that cortical material was, and so the fluid doesn't go posteriorly. That's very common. If you try and hydrodissect in an area with dense cortical cataract, you will find that the fluid does not go posteriorly as well. I think it's because there's no kind of continuity in that area because there's all this cortical material that's fairly liquid. So you can't get a good fluid wave because the fluid has a different egress point. Now we'll get our phaco in. We'll clear the epinucleus, and then we will sculpt. And we'll sculpt our trench and crack. Now remember, we're kind of in an awkward position, so this does kind of go out of frame a little bit, but we'll do a crack and then a chop, and we'll pull out the first quadrant. That's perfect. Second quadrant. Coming out, recenter. Excellent. Rotate. Up, go for a whole heminucleus here. Let's see what we got. Nope, we're going to whole heminucleus. Got it by the other end because that first end didn't come out. No way. Nuclear material is mostly out. We'll go for the cortical material. See that? That's too far out. Don't go that far out when you're getting your epinucleus. That is too far out. And after this, you'll see the clear portion. I thought I broke the capsule. See how clear that is? It looks like there's a capsular opening. So right now we're going to be a little cautious. Let's cover it up because that's what cataract surgeons do. Just kind of cover that area up and take out the rest of the material. Why? Because you don't want any vitreous coming through, but you do want to get out the remainder of the epinucleus. All right, let's see if this comes back into frame here. Fortunately, even though that phaco tip was pretty far out, and if you didn't see it, watch it again, that was too far into the periphery. Fortunately, we didn't have any capsular openings there. We've got all of our nuclear material out, and now we'll go in for our cortex. You can see there's some fluid buildup under the conj there, just like we talked about, we were expecting. Let's get out all this cortical material. That's perfect. Clean up any residual. Great. There's a few cortical strands there, so let's squeegee those, or kind of power wash, I should say. Great. Excellent. Now I've got a nice round capsulorhexis, despite the positioning issues. We're going to put our Provisc in. We will sweep the capsule. And then in this case, I think we use a slightly different lens. It's a B&L LI61AO, which I do like to use in certain situations. It's an excellent lens, but it's silicone, so you have to be mindful of the patients in whom you place this lens. There are some drawbacks to the silicone material, so you do have to keep that in mind. Having said that, the optics are excellent, and kind of the photopsia's visual phenomena are excellent with this lens, so it does work well in many patients. All right, let's get it in there. Sometimes it's a little difficult to place. Silicone lenses, they open up fairly rapidly, so they can be difficult to place in the eye. There we go, we'll get that out of there. We'll place the optic in the capsule and then rotate the lens in. Sometimes this can be difficult, but for the most part, it goes pretty smoothly. Maybe not as smoothly as a single piece lens, but it works very well. There we go. Awesome. So we'll dial that into position. All right, now we'll go behind with our IA and get out any residual viscoelastic. Although that capsulorhexis looks centered with the three-piece lens in there, it seems as though maybe it was a little bit temporal. That's okay. It will still be pretty well covered. We do want to get behind the lens and get all of that residual kind of those cortical wisps. So we'll try and get those out. There we go. That's perfect. Excellent. Now we will get the peripheral viscoelastic out of there, get that lens as centered as possible. We will hydrate our incisions, and the case will be over. So a couple things. Make sure your side part is perpendicular. There are occasions where you have to make it at a different angle, but I think it seals best when it's perpendicular. In addition, be careful going too far in the periphery with your phaco tip, okay? That's where you're getting into trouble, and I just got lucky on this case because that epinucleus came in way more quickly than I was anticipating. It came into the phaco needle way more quickly than I was anticipating, and it could have brought capsule with it. Unfortunately, it didn't. All right, we got a good seal. We will check our incisions with a WEC, and we'll be done. All right, you folks have a great day.